Hi, I'm Dr. Sasha McBain, clinical psychologist and member of the ISTSS Public Information and Education Production Subcommittee. ISTSS strives to disseminate knowledge and promote high quality education and training to improve access to care and quality of care for those impacted by traumatic stress. To meet this objective, the ISTSS Production Subcommittee is collaborating with developers of the interventions highlighted in the ISTSS Prevention and Early Treatment Clinical Guidelines to support widespread dissemination and implementation of the recommended interventions among ISTSS members and the broader public. Today, I'd like to welcome Dr. Doug Zatzik, the developer of the stepped collaborative care model, which was recommended as an early treatment intervention with low effect for traumatic injury survivors. Welcome.
Hi Sasha.
Do you want to say anything more about yourself or give us a brief introduction for our audience?
Yeah, I've been working at U.S. trauma centers on developing early interventions for folks who've been injured for a couple of decades now. But we've also applied these models to folks returning from combat deployments and also internationally. For instance, we did disaster relief work, for instance, after the 2010 Haiti earthquake, and we successfully applied the model, although we didn't do, it's very hard in those things to do rigorous controlled trials. Yeah.
Thank you. Very excited to have you. For those who don't know or may be unfamiliar, can you tell us a little bit more about STEP collaborative care and give us an overview of the model and kind of the key goals?
Sure. Yeah. So STEP collaborative care is meant to be delivered, within hours, days, weeks after a traumatic injury, and really we think there's applicability broadly. It has, we think, fantastic ecologic validity. It can be delivered broadly across populations, and it starts off with really a simple probe, the probe is of everything that's happened to you since your injury. What concerns you the most? Okay. And we think basically it's both a question and it can be used to gain, an alliance with somebody. In the trauma ward, well, I'm in a ton of pain. Okay, well, let's go get your nurse. What are your pain meds? Let's address your pain. And just by asking, that open-ended question and then addressing the issue at hand, the pain or the next, anything else that concerns you. Yeah, well, my kids were in the back seat and they went to a different hospital and here I am. And let's give them a call. Bad motor vehicle crash, and eventually, you may ask that enough that I am having these nightmares, and then you can dive into our more traditional sort of psychological interventions for post-traumatic stress symptoms. And so that's where STEP collaborative care starts. And, you can ask this after someone's been deployed, of everything that's happened since your deployment, what concerns you the most? Oh God, I can't get along with my family, and then, you may begin to address that issue and find out that the individual is a veteran. They can't sleep next to their wife anymore because they're having horrible nightmares. But that probe is neutral enough that you can begin to get sort of a list of therapeutic targets. Now, in the immortal words of Brett Litz, it may be that those targets are inert, but that's okay. In our earliest trial, we started way back when, and debriefing was very popular. And our first trial just tested that probe and addressing those problems, problem solving, for 3 months. And there was no difference with usual care. So we knew we weren't hurting anybody, but it was probably inert. And so what we learned then for step 2, in a sense, was that we had to bring in evidence-based post-traumatic interventions. And we brought in both pharmacotherapy and psychotherapy.
Thank you. You mentioned this a little bit, but are there specific populations, or talk about who this might apply for?
Mm-hmm. So we recruit essentially, we start with random sampling at U.S. level 1 trauma centers, so safety net populations. And we don't, we sort of have a modest effect size. I think I forget, Sasha, what you call it, sort of low low effectiveness. But we think that's made up for, and we actually think a lot about population impact. There's a early intervention review by Malia Gumara in Clinical Psychology Review a few years back that shows there's sort of this balance between effect size and breadth of applicability or reach. We don't exclude people if you're using alcohol or opioids or amphetamine. You're not excluded from our trials. Multiple serious, on average, our patients have 4.5 serious prior traumas before the injury event. Incredibly diverse folks, ethnically and racially, at safety net level 1 trauma center settings. Spanish-speaking folks we've recruited into our trials. So really diverse populations.
I think that's a really important strength of not having to wait, not waiting for something to be in place and being able to take people where they're at and have it be really flexible and adaptable to where they are. Seems like a really great model for implementation. How do you measure treatment outcomes, or thinking about this both at an individual level, but it sounds like also maybe a population or public health level?
Yeah, so we started, of course, with the PTSD checklist, and we actually did a whole trial where we used the CAPS on the phone, and that our major effectiveness findings are published in. We target surgical policymakers, so we publish in the top surgical journals, which are like the Annals of Surgery, which would be like JCCP for psychologists. It's an over 10 impact factor surgical journal, and our most recent publication is in JAMA Surgery. But we use the PTSD checklist as our main outcome measure. And then we also have moved now, there are these health information exchanges, which are sort of spreading across the United States. And those are really nice because they collect automated data on the intent to treat population in your trial. And you don't have to do interview follow-ups. So we've started to use those, and it's looking like care management. The addressing concerns, we call that care management, okay? And it looks like care management and linkage to outpatient surgery, primary care, and mental health specialty, if people will accept the referrals. That in and of itself may be associated with reductions in population level emergency department utilization. Yeah.
Wow, that's great. Can you mentioned a little bit that this can apply to anybody, or that you've tested it with lots of different populations. Given that, how do you ensure that the intervention is culturally sensitive for diverse populations?
Yeah, it's a great question, and some of our early work is more. We're sort of in the epidemiologist intervention developer mode often, and so what we've done is we've done random samples of say 900 injury survivors at our Harborview Hospital, and we found that 1 in 10 may be monolingual, non-English speaking, and that 40 languages are represented. So we've sort of developed this mode. We've tried to learn about specific populations. One trial we did called Staying Connected, published like 2011, just focused on American Indian trauma survivors. And we've focused on specific populations, but we understand that because of the incredible diversity of our trauma center populations, we're going to need a universalist lead interventionist. So when the population is very sort of needs a lot of tailoring, like distant tribal communities in Montana or Alaska, we will try and tailor. But for the most part, we sort of have generalist principles of open-ended questions. We also try and link back to communities. So, you can't have 15 interventionists, but we try and sort of guide our interventions with general principles of cultural acceptance and such. Yeah.
Yeah. Can you speak a little bit to what resources and training are required to implement this intervention or this program?
It's a great question. So it is a complex intervention. There's a lot of moving parts. And the first part is just good case management or care management skills. So, we've had psychologists do this, and actually some of our psychologists have done fantastically, but often a social work background is really good. Even we found, though, for instance, in Haiti, we trained high school level, HIV outreach workers. What you need is sort of a good knowledge of the community from which you're linking your acutely injured folks or your acute care population to the community. So, and really, just really good proactivity. Not really if a referral doesn't go through the first time or a patient doesn't call you back. Really, excellent sort of proactivity is sort of the essence of the care management piece of it. Then we build in, another thing we found early on in our trials was Amy Wagner, who trained at the National Center and then moved to University of Washington, also, worked with Neil Jacobson in behavioral activation. She sort of learned early on the hard way by trying to refer patients to an outpatient, a multi-session outpatient treatment that our patients are they have too many competing demands. They have to go to ortho. They have to, drive 50 miles. So what we've done over the years is we've taken sort of cognitive behavioral therapy sessions and broke them down into elements, okay? And sort of the academic pedigree we follow more, if you know Level 1 trauma centers, our group worked early on getting requirements, mandates for motivational interviewing. And so, rather than a Patty Resick or Edna Foa session-based sort of pedigree, we went with Bill Miller and motivational interviewing, which can be delivered, Rolnick and Miller, 5 minutes in a primary care setting. So we had that already because it's a mandatory part of trauma center care. And then Amy and others have broken down those CBT sessions into cognitive behavioral therapy elements. And Amy has focused in particular on behavioral activation elements delivered within proactive care management. That's very hard to do sort of, dismantled trials on, but when those are embedded with everything else, they seem to do pretty well with care management and pharmacotherapy.
The thing that I find really compelling about that is I think one of the critiques, speaking of access to care, one of the biggest critiques that we get is, and especially with, PTSD, is that we're waiting for people to come to us. And with this population where there's so many barriers, being able to break this down into small pieces and really meet people where they're at and what they need in those kind of early moments, and hopefully to get buy-in for, things later down the road, I think is a really smart approach. And it seems like more and more people are talking about, like, how do we really break down the silos of this work and really truly impact access to care?
I think there's a lot of research to be done on that also. Like I said, we've just, we're sort of hack health services researchers. We just put everything together into a package, but, the really smart clinical psychologists will, of course, dismantle and test discrete elements. You'll do a better job than we've done at that. So.
My next question for you is, what considerations are necessary to ensure the sustainability of the intervention?
That is a really great question, and we're working on that now. Our JAMA surgery paper shows, it's an implementation effectiveness hybrid, effectiveness implementation, that it can be rolled out on 25 level 1 trauma centers, and there's variable quality. Sustainability is more challenging, though. There will be funding issues with this intervention, and so that is something we're really sort of focusing in on now. How are trauma centers trauma centers are safety net settings. They're often strapped, not well funded. And how can we ensure that there are CPT codes and other things for billing? Those are issues we're really sort of bearing down into now.
You've started to speak to this, but have there been any other lessons learned or challenges in terms of implementation, or for those who might be interested in implementing this, that they should be thinking about early on?
Yeah, well, We're doing some coaching. I mean, I think, some folks might not be familiar, but the U.S. trauma care systems are pretty unique in terms of healthcare system implementation, in that you can actually, with the American College of Surgeons, target requirements. I mentioned this earlier there is a requirement for alcohol screening and intervention. So it's really, if you want to be an accredited trauma center with the American College of Surgeons, you have to do that practice. If you go to Australia, we're coaching a group in Melbourne, Melita Gumara's group, and the Australian trauma systems are not like that. They're sort of we call it, there's an old implementation science paper. It's, again, we're sort of, MD, MPHs. We don't think on our feet. The psychologists have much more sophisticated models, but it's in the Milbank Quarterly. It's Teresa Greenhall and colleagues, 2004. They sort of have a really simplistic, you can passive diffusion it, let it happen, you can help it happen, or you can make it happen. So in Australia, it's a help it happen system. So they're doing trials, and they hope to be able to convince policymakers to, help them along their way. In the U.S., if you present the right data to the American College of Surgeons Committee on Trauma, they'll require things. And so it's sort of a different implementation strategy. I actually haven't seen it. You look at those tables Byron Powell puts out. It's mandate plus verification site visit. And, Sasha, you have a paper showing that, just about everybody is doing alcohol screening and brief intervention, and like nobody, or not nobody, 7%, now it's 27% of centers are doing PTSD screening intervention. If it's a mandate, you can draw those mediational lines, but it's going to be close to 100%, right? So the trials target the mandate, and then and that's sort of, again, that's like this notion of effect size and reach. It's usually we're just focused on the effect size, but the implementation effectiveness hybrid targets the mandate, and then you track the processes to tell you what's going to be a problem if you get a mandate. But the target then is what we would call a system level implementation strategy, the mandate and verification and site visit. I don't know. That's how we think about it.
Yeah, I think that's a good point. And one of the things that, I'm always on my soapbox about integrated care, which I imagine that you get on that same box, because I think that's another key component, right? Is like if we're going to make this a recommendation, it's like we need to have the people within the system who have the expert knowledge to help facilitate it, right? And I think that was one thing at my center that was really people responded to, is like, we know that this need exists. We want something, but we don't know where to start. And so for us, it was just like kind of plug and place somebody who knew what they wanted to do and to make it happen. And, there was resources and room to make it happen. So I think people are more aware, and they're interacting with these psychosocial needs in their work every day. But it's like, how do you get the knowledge about what to do with it and what the next steps are in the context of so much other noise and other things that people are having to deal with?
Yeah, and Sasha, you may be, so it's sort of, again, it's this ricochet implementation science. It's not like a set of it's not audit and feedback versus facilitation. It's doing, because the college in the United States is interested in large scale trials and will actually take policy action. Like it may not be that there's a mandate for PTSD screening and intervention, but maybe there's a mandate for general mental health. Somebody at your site sees that, an early adopter site, and they'll say, oh my gosh, we're going to need somebody to develop this as this sort of evolving policy, pragmatic trial dialogue continues over the years. And so that's sort of, so U.S. trauma care, I guess what I'm saying is like, the VA is fantastic, but trauma care systems with sort of open-minded trauma surgical policymakers are a fantastic place for junior folks interested in early trauma interventions to get settled, because I think there's a real openness. It's sort of like you're hitting that S-shaped in in Everett Rogers, you're just hitting the S-shape sort of adoption curve. People are onto the fact that, when we did our EPI studies, it's 70 to 80% of patients who have one problem or another. And it may derive because these are low-income, diverse populations, from safety net settings. They've had multiple 5 prior traumas, but nevertheless, they're going to have PTSD and multiple risk behaviors. And there's a lot to help. There's so much work to do. Yeah.
Yeah, there really is. I wonder, I know you've been at this for a while. Like, how has your thinking about it changed over time, or anything that you, with implementation, that has kind of adapted or shifted, or ways that you might see it shifting as you move forward with this work?
Yeah, I would say to that keeping one foot in research and the other foot in sort of your trauma center organization is really important. If you are working at in a trauma center, you kind of have to keep an eye on what the different organizational pieces are, and sort of just staying in really good establishing really good rapport with your trauma surgical team, the medical providers who will sort of be sort of working with you, on these interventions.
So we can't get away without talking about COVID, and how COVID has presented challenges to implementation, or how you might see this intervention interacting kind of in our COVID world, or what it could look like in terms of navigating those challenges, or how this intervention has been maybe even used with this population.
Yeah. So you talk about implementation sciences. We're hack services researchers, but we know good collaborators. So Larry Polankis, who, a lot of his work is known, especially in implementation science, for, sustainability. We've developed, he's really a trauma anthropologist. He started with work on the Exxon Valdez and has done work in the Southeast after NOLA. So he's done a couple of, right when Seattle was the epicenter for the early outbreak of COVID, and we had developed a method, rapid assessment procedures informed clinical ethnography, with Larry. During our pragmatic trials, we saw that classic sort of in-depth, semi-structured interviews just weren't going to cut it in these large-scale rollouts. So we embed in our trials essentially these ethnographic procedures where the clinicians implementing the trial take log field notes and jottings, and then present back to Larry once a month, and sort of it's a rapid ethnographic procedure. So we had these procedures up and running when COVID hit in Seattle in one of our trials, and so we have 2 papers. One is from March 2020, and the other is April 2020, sort of describing the modification of the intervention for the COVID surge. So one, there were just clear low-hanging fruit made from these sort of rapid ethnographic observations. I mean, one was that basically, Harborview has, as I imagine other spots, in the Southeast, Arkansas, I'm sure, reaches to all sort of corners of the state, for being the level 1. So we reach out to Montana and Alaska. And so an early observation is that we were going to bring people back to Harborview because we have great orthopedics here. But, why force people to come to the COVID dense area? Why not be more proactive with collaborative care and have people, it seems like a no-brainer, but it's just the kind of thing, before all the telehealth was going, we basically were much more proactively looking for practices, orthopedics practices in Eastern Washington for people to follow up with, and supporting. It wasn't formal telehealth at that time, but getting our orthopedic providers more sort of in tune to support that outpatient referral to a distant practice. We did a lot of other things as well, but those rapid ethnographic procedures we think are a key piece to sort of there's all the Shannon Whitsley Sermon's work on adaptation and modification, and then Russ Glasgow's group sort of is doing the bite-sized work on that. We think it's even more. It's sort of implementation science methods light. But it comes in handy when you're just on the fly in the middle of the pandemic. So basically, yeah, we have a couple publications on modifications for COVID, and also some methodologic stuff as well. So.
Very cool. It sounds like you keep saying you're a hack health services research, but you
We,
do look pretty good for a hack.
yeah, 2 standard deviations below or above the mean. The problem is you never can tell which one it is. So, as Sarah Landis says, don't listen to him. Get about 10 other people to talk to before you go with his ideas. That's a quote.
I
So,
love it. Thank you so much
yeah,
for this.
you're
Before
welcome.
we end for today, for those who are interested in learning more, where should we point people? Give us some recommendations.
Yeah, so we have a lot of we have a lot of publications, and we don't tend to we work a lot with the American College of Students, so we don't tend to have huge website presence. But I'm always contactable. We sort of are in cahoots with the college, and we just let them do a lot of our dissemination work. So yeah.
Thank you so much, and we'll
You're
end there.
welcome. Yeah.